So we are going live in 5, 4, 3, 2, 1. Please start, sir. We are live.
Hello, good evening. Good evening, everyone, and it's a great pleasure to welcome you all for this exciting webinar on changing treatment landscape in lung cancer. This is done under the aegis of Cancer Research and Strategic Foundation. It's a pleasure to welcome and invite Dr. Sandeep Pupkar, head of the Department of Medical Oncology at Sohana Cancer Research Institute, Chandigarh. So good evening once again, and it's a great pleasure to welcome you all. Good evening, Dr. Sandeep, sir. Over to you for the introduction, and then you need to invite the speakers, please. Unfortunately, Dr. Rajesh Singh will join by 7 p.m., so you can take the lead, sir. Over to you, please.
So good evening, everyone. Am I audible?
Yes, sir, you're audible, sir. Go ahead, sir.
So good evening, everyone. I, on behalf of Sohana Hospital, welcome you all for this academic event. And without any delay, I would invite Dr. Vamshi for his talk on overview of molecular oncology in lung cancer and our dilemmas in testing of exon 14 skipping. So we all know that lung cancer is upcoming on the horizon with the molecular landscape and the onset of driver mutations and their usage in our clinical day-to-day practice. So it is very, very important to know what are the modalities that can be used for diagnostic purposes as well as their clinical implications. So over to you, Dr. Vamshi.
Thank you, Dr. Sandeep. Can I share my screen? Is my screen visible?
Yes, sir.
Okay, is it full screen now?
Yes.
Right. So thank you for the opportunity. And I'm going to talk about overview of molecular oncology in lung cancer. I will have a couple of slides on reference for the MET exon 14 skipping mutation. I presume my next speaker is also going to speak on that. So I've kept it to a little bit of minimum. If you look at the histological classification of non-small cell lung carcinoma, classified by the WHO and the International Association for Study on Lung Cancer, there are three main subtypes. And the one which we usually see in our day-to-day practice is the adenocarcinoma, part of non-small cell lung carcinoma, which does have its histological heterogeneity. The other non-small cell lung carcinoma is squamous cell carcinoma, comprising about 30%. It is usually centrally located compared to adenocarcinomas, which are peripherally located. And a strong association with smoking is usually seen in squamous cell carcinoma compared to adenocarcinomas, wherein non-smokers usually have, certain 85% have some other EGFR mutations. And the other would be large cell carcinoma. So if you look at the evolution from histology to molecular, non-small cell lung carcinoma was considered one disease, which had no targeted therapy at that point of time. And then histologically, we were able to differentiate into squamous cell carcinoma and adenocarcinomas based on immunohistochemistry markers, like for squamous cell carcinomas, P63, CK5/6 at that point of time, and now replaced by P40. Adenocarcinomas, the nuclear and the cytoplasmic markers, NAP-A and TTF1. And if you look at the molecular makeup of adenocarcinomas, EGFR sensitizing mutations comprise 17% in this particular study, whereas there is varying difference of positivity between Caucasian population, which is minimal, about 2% to 5% 5 years back, now being increased to 10 to 15%. And if you look at Asian population, it is about 40%. And in India, I presume if we have a study in India, it would be around 50 to 60% as well. And then the others are KRAS, 25%, ALK, then MET, ROS1, BRAF, RET, the pan tumor agnostic markers like NTRK, and you still have no oncogenic driver mutations detected in about 30% of mutations. So this was histology to molecular, especially adenocarcinomas. But if you look at non-small cell lung carcinomas, adenocarcinoma and squamous cell carcinomas, these are two different entities molecularly. Primarily, we talk about adenocarcinomas, and we look at adenocarcinomas in our day-to-day practice, where we look at EGFR mutations, ALK mutations, BRAF mutations, ROS, RET, MET, NTRK1, and other driver mutations in the form of a TMB or immune checkpoint like PDL1. But if you look at squamous cell carcinomas, they are a totally different molecular entity, wherein you have EGFR V3 mutations, FGFR1, PIK3CA, PTEN, PDFRA, FGFR2 fusions, etc. So this is another figure, kind of pie chart looking at the driver mutations in squamous cell lung carcinomas. Here also you have about 25% of unknown mutations that we do not know. So non-small cell lung carcinoma, coming back to the adenocarcinomas, wherein early stage and metastatic disease would have your EGFR mutations. And KRAS is the next major mutated gene marker for your targeted therapy. So how to establish a diagnosis? The primary way to establish a diagnosis would be a tissue biopsy. Fixation time usually less than 24 hours for smaller biopsies, and hematoxylin and eosin tells you whether, histologically you can put it into an adenocarcinoma or a squamous cell carcinoma. And one histochemistry marker, one IHC marker each to be used for squamous and adeno to store, or rather to preserve the tissue for the next molecular sort of targeted therapy. And liquid biopsy is one more, recommended sort of. It's not really a recommendation, but it is a standard practice of care, at least in the US, to establish a diagnosis of non-small cell lung carcinoma. We have lots in the diagnostic armamentarium in the laboratory to look at various mutations which are present in non-small cell lung carcinoma, starting from Sanger sequencing, a fragmented analysis that we look at for your MET exon 14 skipping mutation, ASPCR, real-time PCR, ARMS PCR, which is the usual companion diagnostic in the form of TheraScreen for your EGFR mutations, FISH, pyrosequencing, next-generation sequencing, and Doppler digital PCR. Tissue biopsy is essential at diagnosis. It tells you the heterogeneity of the tumor. And at relapse, it tells you, it identifies the resistance mechanisms like histological transformation in small cell lung carcinoma, MET amplifications, or HER2 alterations. At relapse, a tissue biopsy can be subjected to Doppler digital PCR if you have a specific mutation that you would like to know, or any secondary resistance mechanisms that you can understand on FISH. And of course, next generation sequencing gives you a comprehensive understanding of the disease, in hand. What are the therapy predictive biomarker testings? There are two testing streams. One is to find the targetable oncogenic alteration, and two is an immuno-oncology therapy. So the updated molecular testing guidelines tell you that the analytical methods should be looking at least 20% or more of malignant cells in the tissue. Because if you want to look at a Sanger testing, and molecular testing is not recommended in squamous cell carcinomas, for these particular genetic alterations that we're looking at for adenocarcinomas. And if there is a smoker or a light smoker, or somebody who we have not really got the adenocarcinoma component because of tumor heterogeneity, then, or an adenosquamous cell carcinoma, then we go for these targetable alteration testing. Since the past 2 decades, there have been more than 40 drugs which have been approved for EGFR, ALK, RET, MET, and other alterations. And if you look at the green ones, these are the landmark therapeutic molecular targets. 2004, it was EGFR. It was 2011, BRAF. And now in 2019, it's the NTRK fusions, which are preferably tumor agnostic, not only non-small cell lung carcinoma, but also in any other solid tumors. And if you look at the technology, then 2005, it was NGS, which was approved, and we still use that, at this moment. A few slides on NCCN guidelines, wherein we look at the evolution of biomarkers, which were FDA approved. If you look at in 2018, there was ALK, EGFR, ROS, BRAF. There were 4 known actionable driver mutations. Come 2020, this number has increased to 6 with the addition of MET and RET. 2021, there are the known actionables, as I would want to call them as, was EGFR exon 20, KRAS, G12C, wherein sotorasib was introduced, ALK, ROS, BRAF, MET exon 14 skipping mutation, NTRK, RET, and the PDL1 mutation. 2022, the actionables have increased. At least the classification of these alterations has increased to 13. driver mutations. And this is where we stand now in 2022. Coming to individual mutation alterations, EGFR mutation detection, we look at exons 18 to 21. And the most common ones are the L858R and the deletion in exon 19. We check in the lab. We can check for various techniques, which is in Sanger, real-time PCR, the next generation sequencing, or the droplet digital PCR. 85 to 90% of these mutations are L858R and L19. The secondary resistance mutation being T790M, preferably checked over droplet digital PCR, and then the tertiary resistance mutation in the form of C797S, which can be checked on liquid biopsy or on tissue biopsy by droplet digital PCR, which would give you a good sensitive technique. The next would be ALK gene rearrangement, EML4 ALK being the most common. 2 to 5% of these alterations are seen in non-small cell lung carcinoma. IHC is an acceptable alternative to FISH for the therapy initiation, the companion diagnostic being crizotinib. We look at 50 tumor cells, and at least 15 tumor cells we need positive to call it as ALK rearranged. ROS1 gene rearrangement, about 2 to 3% incidence in non-small cell lung carcinoma. They're common fusion partners in the form of SLC34A2, CD74TPM3, and GOPC1, which is also seen on the NGS. The IHCs D4D6 and SP384, they're not recommended as primary treatment determining tests. IHC, because the interpretation of by IHC on the ROS1 rearrangement is challenging, and FISH is required for the diagnosis. NGS is always present as an alternative. 1 to 4% of these non-small cell lung carcinomas also show RET gene rearrangement. The common fusion partner is KIF5P. The IHC antibody would be AB134100. And as usual, you have to look at the FISH RET rearrangements for therapy initiation. But FISH can be particularly challenging because there is a very narrow spacing between the two probes which have been designed. So we have to look that carefully. It's the same 15% positivity that we look at for 50 cells. KRAS, the point mutation G12C has been the companion diagnostic for sotorasib. And usually these mutations that I'm mentioning are mutually exclusive. So this G12C can be caught on various lab techniques in the form of real-time PCR, NGS, and droplet digital PCR as well. BRAF V600E being the point mutation, you have your dabrafenib and trametinib. 2% of non-small cell lung carcinomas show you BRAF positivity. You can look at this single point mutation by Sanger sequencing, ASPCR, real-time PCR, NGS, or droplet digital PCR. The tumor agnostic marker, NTRK123 gene fusions, or rather gene alterations, gene rearrangements are seen on IHC and NGS, and a positive IHC would require confirmation by a validated molecular method, which is FISH or NGS, like the other gene rearrangements.
Sir, wonderful presentation. Last 2 minutes to conclude, please.
Okay, thank you. So MET gene alterations usually are mutations or a skipping mutation. MET exon skipping mutations would be covered by my next speaker. However, I would want to say that this is the recent paper which was just released last month, calling for essential considerations of current management of non-small cell lung carcinoma, in which we can see various mutations in the form of SNVs or indels, which delete the exon 14. So when the exon 14 or the juxtamembrane part of this receptor is not deleted, then there is no degradation and there is signal upregulation, which would cause this particular thing. The testing dilemma would be whether to go for a DNA-based assay or an RNA-based assay. However, the RNA-based assays are much superior to the DNA-based mutation. If you see here, this is an NGS wherein exon 13 and exon 15 have come together, and these are multiple reads that you're looking at. So the exon 14 has been skipped or has been deleted because of the splicing mutation. There are other immune checkpoint that I was talking about, the PDL1. You can look at by IHC, and the tumor mutation burden, which is a tumor agnostic marker. Tissue optimization we need to look at based on the sensitivity of various techniques that we look at, and the next generation sequencing based detection of these driver mutations is the most preferred these days. A comprehensive genomic profiling, where you want to look at these SNPs, you want to look at small little indels. including your MET exon 14 skipping mutation, copy number alteration in the form of HER2 or MET, or any rearrangements in the form of gene fusions, any tumor agnostic genomic signatures like TMB and MSI are better if you can look at comprehensive genomic profiling, especially for carcinoma of unknown primary. So conventional testing would not look at a single gene or a small hotspot NGS panel. It would look at the entire tumor for its actionable variants, and this would be preferred because we would unlock the unknown. All the indels, single nucleotide variants, fusions, your splice variants in the form of MET exon 14, then copy number variations, your MSI, which is tumor agnostic marker as well, and you can look at all this thing by a comprehensive genomic profiling. Liquid biopsy at diagnosis lacks sensitivity, but at relapse, it is the best to look at your mutations in the form of resistance mutations in the form of T790M or C797S. And this is a data of 950 samples, wherein we have 31% of EGFR mutant, 15% of KRAS, 3% BRAF, 7% ALK, 2% of MET exon 14 skipping, and no pathogenic mutations, about 30%, as is seen in the literature. So I thank you for your time, and that would be all from my side. Thank you.
So thank you, Dr. Vamshi. That was a great learning from you on the testing techniques as well as on the insights of testing of molecular testing in the lung cancer. Just a quick question. What do you usually prefer? Is it a RNA-based technique, or nowadays you are using dual techniques, DNA and RNA-based? And does it add to any additional cost while using the methods?
So what happens is, if it's always better to have another technique, especially when it is a target therapy and which is new. Say an RNA-based technique, as I just mentioned, is superior to a DNA-based technique, especially when you're looking at fusions, especially when you're looking at alterations. So MET exon 14 skipping mutation is always better to look at RNA. And we look at, if you are doing another technique, it's always better to mention it in your report so that you have dual confidence in giving the right therapy to the patient. And there's no dilemma in the minds of the laboratory person or the clinician that we are looking at a MET exon 14 skipping mutation.
Okay. So going on to the next session, I invite one of the senior consultants from the prestigious Rajiv Gandhi Cancer Institute, Dr. Sunil Pasrija, who does not need any introduction, and will straightforward move on to his topic, biomarker testing, and our focus is again on MET exon skipping. Some new insights and some new learnings from you, sir.
Thank you, Dr. Sandeep. Am I audible?
Yes, sir, you are audible.
Yeah. Thanks a lot for inviting me on this prestigious platform, and I would like to thank the organizers, and it's really a pleasure to be here with all of you. So can I share my screen?
Yes, sir, you can share slides.
I'll just put it on the PPT mode. Okay. So my slides are visible moving?
Yes, sir.
Okay, so I'll be talking about the predictive biomarker testing in lung cancer with a focus on MET exon skipping mutation. So I will cover the MET exon skipping mutation in detail as compared to the other biomarkers. So tissue is the issue, and the endoscopist radiologist should be encouraged to perform multiple sampling, ideally 5 cores, and pathologists should manage these cores wisely and judiciously. One has to rely on the morphology and limited IHC and save the tissue for the molecular analysis. So we know that 90% of the lung cancers, they are non-small cell lung cancer, and the role of the pathologist in the present era is not only just to diagnose a lung cancer, but also to find out the predictive biomarker so that the patient can be put on the targeted therapy. And why it is important? Because this was the survival of the patient with drivers in lung cancer mutation consortium, and total 733 patients were analyzed for 10 genes. And in 64% there were some identified the mutations, while 36% no driver were identified. And we can see very clearly in this graph that the survival probability, if we see, so there is a good prognostic separation of the curves when the patient were put on the targeted therapy, which is highlighted by this orange graph. So they had a better survival as compared to the patient in which no targeted therapy was given or when no driver were identified. So the consortium demonstrated that the best outcomes are seen in the patient with identified drivers placed on targeted therapy with 3.5 years median survival. So although EGFR ALK, they makes the bulk of the targeted biomarkers, but there is a potential applications in uncommon mutation beyond EGFR and ALK, and that makes around 15%. So a biomarker testing in lung cancer is always a moving target, as Dr. Vamshi has already alluded to in his talk. So a couple of years back, we had two broad categories. One is the minimum necessary, which is a must-do test. That is, you have to do EGFR, ALK cross, BRAF, and PDL1. While the second category is recommended, which is should-do test. As far as possible, we should do it. That is RET, MET exon 14, HER2, KRAS, NTRK, and few more have added in the last 2 years. So starting with the EGFR, it's the most robust predictive biomarkers for response to EGFR TKIs. It confers a more favorable prognosis, and therefore a targeted therapy should be used ahead of chemotherapy and immunotherapy in EGFR positive NSCLC. And especially in Asian population lung adenocarcinoma, there is up to 60% incidence, especially among the non-smoker females. Therefore, a great effort has been made to standardize the diagnostic test, and approximately 90% of all the EGFR mutations, they consist of either a deletion in exon 19 or a point mutation, that is L858R in exon 21. So two FDA-approved test kits we are having both at our institute at RGCI, the COBAS EGFR mutation test and COBAS EGFR mutation test V2 for T790M mutation, and also QIAGEN TheraScreen PCR kit. So these tests are highly sensitive and can detect the mutation in samples with tumor infiltration as low as 10 to 20%. Unfortunately, the resistance to TKI are inevitable. And these are the various molecular mechanisms that actually causes the resistance post first-line EGFR TKIs, of which T790M alone accounts for around 50% of the cases, and the drug of choice is osimertinib. So here also comes the role of liquid biopsy. Like several studies have supported the use of plasma genotyping as the first-line testing to detect T790M, and which has now stood the test of time. And the tissue biopsy would be required only when T790M is not detected in the plasma, as false negative rate of 30% is associated with plasma genotyping. However, the treatment response to either a tissue or a plasma detected sensitizing mutation is absolutely same. The established use of first-line osimertinib now may largely prevent the development of T790M resistance and has a better CNS penetration. Coming to the ALK rearrangement, so more than 12 different variants of EML, ALK variants, and non-EML fusion genes have been detected. The impact of the ALK variants on the heterogeneity of the response to ALK inhibitor has not been fully elucidated till date. It is seen in 5 to 8% of the patient with advanced NSCLC, commonly seen in young non-smokers. And this systemic review and meta-analysis study of 12 studies, they have shown that the superiority of the ALK inhibitor over the chemotherapy in the terms of progression-free survival and overall response rate, and also the next generation agents, that is alectinib, brigatinib, yielded a better response intracranially than crizotinib in terms of objective response rate and time to CNS progression. So these are the methods of detection if you're going for a single gene assay. So immunohistochemistry and FISH is we are doing routinely, and NGS as a part of multi-gene assay. So here in basically in the break apart FISH, one probe is tagged to the ALK region and the other probe is tagged just adjacent to the ALK region. So if there is a rearrangement, we can see this break apart signals of these two probes, which are having a different color codes. This is the immunohistochemistry. So at our institute, we are doing ALK IHC upfront. So we can see the positive, even if there is a strong immunoexpression, the test is considered positive. Even with the moderate intensity, the test is still considered positive, but we have to take positive and negative controls along with the test. So immunohistochemistry definitely has advantages, as it is faster, cheaper, standardization is easier, more labs can do it, it is reliable as the normal lung tissue do not express ALK, and D5F3 monoclonal antibody is used on Ventana platform, has been FDA approved as a companion diagnostic for crizotinib, and we are using this antibody at our institute. The superiority of the TKI, the crizotinib over chemotherapy in the first line ALK positive advanced NSCLC was proven in 2014. However, the resistance to treatment invariably develops often with the progression in the brain. And the second and third generation TKIs have proven their better efficacy. The third generation lorlatinib who led to 72% improvement in PFS compared with the crizotinib in the first line treatment. Coming to the ROS1, the ROS1 oncogene 1 is a receptor tyrosine kinase seen in 1 to 2% of the NSCLC, the rearrangement, and that is because of the translocation between the ROS1 and the other genes. The most common is the CD74. That leads to activation of the downstream oncogenic pathway leading to oncogenesis. And this rearrangement is sensitive to the ROS1 inhibitor. Crizotinib and entrectinib are FDA approved. Coming to the methods of detection, the FISH break apart is recommended as a single gene assay, while NGS is recommended as a part of multi-gene. However, immunohistochemistry is a very effective way of screening. Like we are using this antibody since last 4-5 years, D4, D6 from cell signaling antibody, which is recommended antibody, and also recently SP384 from Ventana. So, but the bottom line is that these immunohistochemistry is very sensitive but not specific, as they may be associated with the false positive rate. So the bottom line is that all positive immunohistochemistry cases must be confirmed with FISH analysis before starting on targeted therapy. So this was the case I had in my case library with the Acinar pattern and showing a ROS strong and diffuse immunoexpression, which was eventually showed rearrangement on FISH testing. BRAF mutation. So BRAF is a downstream signaling mediator of KRAS that activates the MAP kinase pathway. The activating mutations are observed in 1 to 3%, and the mutation can occur at V600 position of exon 15 or outside this domain. And NSCLC patient who progressed on chemotherapy, the combination of BRAF and MEK inhibitor, that is dabrafenib and trametinib, has been approved by FDA. And regarding the preferred testing methods, PCR sequencing when going for a single gene, while NGS for a multi-gene assay. So these were the initial encouraging trials that have proven the efficacy when the dabrafenib plus trametinib could represent a new targeted therapy with robust anti-tumor activity and manageable safety profile in patients with previously treated or untreated BRAF V600E mutant NSCLC. So coming to these were the must-do tests. Now coming to the recommended or should-do tests. So MET exon skipping mutation or amplification, they can cause a dysregulation of the MET pathways. So basically MET is a proto-oncogene that encodes a tyrosine kinase receptor regulating the cell survival, proliferation and motility. And this gene is located on chromosome 7, which encodes for the receptor tyrosine kinase that activates the downstream signaling pathway, including the MAP kinase, PI3K and nuclear factor kappa B. In normal conditions, the MET pathway is activated by binding of its ligand hepatocyte growth factor. So what happens is when the mutations that actually disrupt the splice site flanking the MET exon 14 result in MET exon skipping. So we can see that these mutations that disrupt the splice sites. So ultimately in messenger RNA transcript, we can see that the exon 14 is skipped. So it is eliminated. Now exon 14 encodes for a very important juxtamembrane domain, that is Y1003, which is actually a binding site for the CCLB, which is required for ubiquitination by a proteasome degradation pathway. So what happens is when the MET exon when the exon 14 is skipped, so this will be a truncated MET protein without the absence, so without this binding site for the ubiquitination, so there will be no ubiquitination. Now that will lead to a constitutive activation of the MET pathway because the MET protein is not degraded. So what is the characteristic of the NSCLC with the MET exon 14 skipping mutation? So they are seen in 3 to 4% of all the metastatic NSCLC, can be associated with MET amplification, copy number variants, commonly seen in female, elderly, non-smokers, and are highly predictive of response to MET inhibitors. The FDA approved capmatinib and tepotinib for metastatic NSCLC whose tumors have a mutation, that is a MET exon 14 skipping, as detected by FDA approved test. Now, MET exon 14 is also an independent indicator for a poor prognosis, shorter overall survival in NSCLC patient, as studies have shown. And we can see that as compared to the wild type, there is a prognostic separation of the curves in this Kaplan-Meier survival curves. So, detecting the MET exon 14 mutation and the challenges. Although these alterations, they are found, initially they were discovered by the whole exome sequencing, large hybrid capture-based NGS or Sanger sequencing of the MET. But in routine clinical practice, such technologies are not feasible due to high cost, prolonged turnaround time, and require larger tumor samples with high tumor fractions. So targeted NGS allows comprehensive routine molecular profiling of tumor sample, enabling the detection of known altered oncogenes and tumor suppressors. Now, FDA has approved the Foundation One to aid in the detection of MET exon 14 in tumor tissue. But by this time, we have familiarized that there are disadvantages of the DNA-based sequencing, because DNA sequencing can only detect a genomic variant that alters or removes a splicing site. The sensitivity of amplicon-mediated DNA-based approach is not optimal. The commercially available probes in the amplicon-mediated DNA-based approaches does not cover the sufficient region of interest, because the mutations which are present in the intronic regions, the commercially available probes do not cover those areas extensively. So a lot chances of missing these mutations, and also because of the huge diversity and specific localization of these alterations. So RNA-based sequencing is preferred over a DNA-based NGS. And the RNA sequencing has an advantage because it encompasses all the causal genomic events actually that leads to exon 14 skipping, and hence being more sensitive. RNA sequencing detects the fusion of the exon 13 to 15. And in one study, approximately 60% of RNA positive results were found to be false negative in DNA assays, which was published in JTO 2019. So basically, for a DNA, you have to look for the mutation indels, which are many may still be unknown, and the sensitivity is not up to the mark. While for the messenger RNA, you have to assess the altered sequence. The sequence of the bases are assigned to exon 14 is missing. So a sequence of shorter length by 140 base pair, which is attributed to exon 14 skipping, will be lesser. So it has a near perfect sensitivity. So this can be explained very easily from this diagram. So when there is a normal messenger RNA and exon 14 the exon 14 is there, so we have n number of base pairs. And what happens when exon 14 is skipped? So here exon 14 is eliminated. So what will happen? The number of base pair read will be n minus 140, which where the 140 is attributed to exon 14. So MET amplification is also a mechanism of MET dysregulation. MET amplification results in increased messenger RNA and MET protein overexpression and causes constitutively signaling and kinase activation. MET amplification is regarded as a primary driver mutation and also one of the main mechanism of EGFR TKI resistance, depending upon the assay and the positivity cut point used. The occurrence of de novo MET amplification is around 1 to 6% in lung cancer, and many studies have associated MET amplification with the shorter survival. However, the high amplification with the ratio of MET to SEP7 ratio more than 5 appears to be the strongest predictor of a true MET-driven tumor, which is seen in 0.34% of lung adenocarcinoma. MET is also a co-driver in NSCLC. MET amplification in EGFR mutated NSCLC comprises of 5 to 15% of EGFR mutated tumors that have acquired resistance to TKI. Liquid biopsy might be an important tool to use in this situation to detect the secondary mutation without repeat biopsy and discomfort. And now with osimertinib as a first-line choice, the spectrum and association of MET mutation will remain to be seen in near future. And MET amplification is also associated with poor survival in NSCLC patient, as we can see from these the Kaplan-Meier curves. So regarding the detection method, the FISH is the first validated technique, and NGS may provide additional information on other potentially clinically relevant, and they also provide concurrent genomic alterations. Regarding HER2 mutation, HER2 is
Dr. Sunil sir, excellent presentation as always. Request if you can conclude, please.
How many? I have 2 minutes.
Yes, sir. 2 minutes.
Okay, I'll conclude. So HER2 again, it's seen in 1 to 3%. Majority are in frame insertion in exon 20. And the early phase clinical trial suggests that the patient with the tumor harboring these mutations who progressed on chemotherapy may respond to trastuzumab-based regime. However, no benefit for trastuzumab for HER2 amplification. The RET has already been covered. So NTRK fusion, they have a prevalence of up to 1%. Larotrectinib and tractinib are the 2 FDA-approved oral TRK inhibitors, which are approved in the tissue agnostic fashion. And recommended method is NGS as a part of multi-gene assay. Immunohistochemistry, we are using this as a screening only, the clone EPR17341. We are having this at our institute, which shows strong cytoplasmic staining. However, it has to be confirmed with NGS or FISH, and standalone tests are not cost effective. And larotrectinib has been approved. These are very rare. NRG1, I can skip that. And this is the RAS mutations, the activating KRAS mutations, which activate the number of downstream signaling pathway are observed in 25% of lung adenocarcinoma. The recommended method is NGS. The multiple agents specifically targeting the KRAS G12C mutation in NSCLC have emerged. Sotorasib is approved by FDA for KRAS G12C mutated locally advanced or metastatic NSCLC who have received at least one prior systemic therapy. So NGS is preferred over a single gene assay because it is tissue proficient. 10 nanogram of input of DNA RNA is sufficient, and it's also a resource proficient. One experiment, just one platform. And depending upon the alterations like tier 1, tier 2, and tier 3 alteration,
One
the patient
minute,
can be.
please. 1 minute, please.
Okay. 1 minute is remaining.
Kindly finish.
Okay. So I can skip this the biomarker, immunotherapy biomarker. So PDL of all these biomarkers, PDL1 has actually emerged with the passable utility, and NCCN has guidelines have approved the pembrolizumab immunotherapy in the first line as a monotherapy when PDL1 expression is more than 50%, and these are the standard recommendations in the first line and the second line. And one has to use the companion diagnostic assays. So to conclude, there is an extensive role of biomarker testing in advanced NSCLC adenocarcinoma, especially. The broad molecular testing and liquid biopsy are making a big way as a tools for biomarker assays. Multidisciplinary communication is essential for the quality information within the required time frame, at a judicious cost. And it's incumbent upon pathologists to make the testing reliable by optimizing pre-analytical, analytical, and post-analytical steps. Thank you.
Thank you, Dr. Sunil. That was a wonderful presentation. I've been, there was lack of support of lab a couple of years back, but now the labs are also coming in India. Also, they're coming with especially this rare mutation analysis, NGS and all. Thank you very much. And we now proceed on to next session. Any question by anyone? Any questions from audience?
Sorry to interrupt you, sir. Just a warm welcome from our side on this occasion. So I welcome Dr. Rajeshwar Singh, sir, who has been our mentor in the Tri-City and has been a part of our meetings and has led his guidance in innovating oncology in the Tri-City and the surrounding areas. So a warm welcome, sir. And I invite you to take on the proceedings. And just a bit of this thing that Dr. Sajjan has to leave, so he has requested that his presentation should be taken if it is possible. So I would request you, sir, to invite Dr. Sajjan, and then we'll take the proceedings forward. Thank you, sir.
Thank you, Dr. Sandeep, for your nice, few words about me. Now we proceed on to the selecting the best therapy in the first line EGFR mutated non-small cell lung cancer and the role of osimertinib for EGFR mutated NLCS. First line. So I invite Dr. Sajjan Raj Purohit. He is a Director, Department of Medical Oncology, BLK, as well as Max Super Specialty Hospital in Delhi. Dr. Sajjan, please. Kindly stick to your time. Request.
Yeah, thank you so much, sir. And I'm sorry because I'm not able to turn on my camera because of the narrow bandwidth. So the presentation has been put up by the organizers, and again thanking all of you for this kind invitation. So over next 10-15 minutes, I'll speak on osimertinib and why most clinicians feel that it might be the first choice for EGFR positive lung cancer patients. Next slide, please. Okay, next slide. So we all know that lung cancer is the most common cause of death worldwide by both men and women. And when we see there's more and more rise of adenocarcinomas, and especially oncogenic driver mutation driven cancers. And if we just see the global data, 13% of the all new cancer patients is lung cancer, and 19% of all the cancer related deaths are because of lung cancer. Again, data from India again shows that almost every year, more than 70,000 patients of lung cancer are diagnosed. And again, it accounts for 9.3% of all cancer deaths every year. And the prevalence rate is 1.8% of all the cancers. And that's because the prevalence rate is much lower compared to the incidence because of the higher mortality. And the highest reports are from Mizoram as well as for both males and females. Next slide. So 57% of lung cancer patients are diagnosed after metastasis and leading to 5-year survival rates of just 5%. And that is why, because most of these patients, in fact, in many of our practices, we will have almost 70 to 80% patients being diagnosed in stage 4 even today. So if you just compare to the average of 5-year survival for all the patients, which is 5%, but if you just see the population which is EGFR positive, the survival rates are 15%. So at least it is 3 times higher in the EGFR mutation positive lung cancer patient compared to the overall population. That means that EGFR is a favorable prognostic factor for a lung cancer patient. Next slide. The good thing is that now more and more targets are being found in lung cancer. And if we just see a decade back, we hardly had EGFR, ALK as major markers. But now, if we just see a metastatic lung cancer patient, we would have immunotherapy markers being positive in the form of PD-L1, almost in the tune of 30 to 40% patients. We'll have a big segment of patients who are now being found as KRAS mutation. Again, it was positive, but then we didn't have any drug. Very recently, we have got a drug which has got approved for KRAS mutation positive patients. And then we have EGFR, ALK, HER2/neu, BRAF, PIK3, CA, MET, NRAS, ALK, AKT, and MEK. So a lot of, I would say that almost a 60% chunk has got some form of either immunotherapy markers or oncogenic driver mutations as of now. Next slide. So EGFR activating mutations result in constant signaling, and a constant signaling downstream. There's a upregulation and a constant signaling in the EGFR pathway through the RAS, RAF, as well as other pathways, and a lot of intercellular cross communication happening downstream. So the common mutations are L858R, then exon del19, as well as there are some resistant mutations which can be again upfront or more so on first and second generation TKI, which are T790M. Next slide. So osimertinib is the third generation irreversible CNS active TKI, which is both selective for EGFR mutation as well as for EGFR T790M resistant mutations. So it has got a broad spectrum of activity against the various mutations which can happen in del19 or exon 21, and also a secondary mutation which is T790M. Next slide, please. So if we just see the first generation versus second and third generation, the best thing about osimertinib is it irreversibly inhibits the EGFR binding. It does not affect the wild type EGFR, and that's what leads to lesser degree of rashes and other side effects, which can otherwise happen very commonly with the first and second generation TKIs. Then it has got the high potency against del19 and L858R, which constitute almost 85 to 90% of all they are the most common mutations in EGFR. Then also highly potent against T790M, which is the most common way of acquiring resistance to the first and second generation TKIs. And apart from then, blood-brain penetration has been almost 5 to 10 times higher. In fact, for asymptomatic brain metastasis, osimertinib itself is a very potent drug. And the third generation drugs which we have is osimertinib, and again another drug is roselitinib. Next slide. And first and second generation drugs are geftinib and erlotinib, and then followed by afatinib and dacomitinib. So now coming to FLORA. So FLORA was a landmark trial. It was a randomized double-blinded phase 3 study to assess the safety and efficacy of osimertinib versus the standard of care EGFR TKI as the first line in patients with locally advanced or metastatic EGFR mutation positive non-small cell lung cancer. Next slide. So if you just see the trial schema here, the patients with locally advanced metastatic patients with inclusion criteria of more than 18 years of age, WHO performance status of 0, 1, exon 19 deletion or L858R, or no prior systemic anti-cancer treatment, and stable brain mets were allowed in this study, which was again very similar to the real life experience, because many of our patients, almost 20% of the patients, will actually have a asymptomatic brain metastasis to begin with in EGFR mutated lung cancer patients, and they were randomized equally to 1:1 osimertinib 80 milligrams per day versus the physician's choice of EGFR TKI, which was either gefnib or lorlatinib, and then both the drugs were continued till disease progression, and also a crossover was allowed in the standard of care in patients in the comparator arm. The primary endpoint was PFS based upon the investigator assessed RECIST criteria, and the second endpoints were objective response rate, OS, duration response, and patient reported outcomes and safety. Next slide. So if we just see, it was a large study of more than 500 patients. So if we just see the baseline characteristics, males were around 30 to 35%, and females were around 65%. The median age was 64 years in both the arms. The patients were both whites, Asians. There was a large proportion of Asian population. Almost 60% of patients were Asians. 35% patients were the white population. The smoking status, never smokers were around 65%. CNS metastases were present in almost 19 to 20%. So that's a kind of an average. The normal population statistics are also similar in the tune of 20%. So almost 19 to 20% patients were there in both the arms. PS performance status was good, and the distribution was deletion 19 was 60%, and deletion L8 858R was around 40%. Next slide. So if you just see for the PFS, which is the primary endpoint for the study, if we just see here, so this is one landmark trial where we have seen there was an early separation of curves to begin with, and the curves continued to separate over a span of 24 months. So the median survival, the median PFS was 10.2 months in the standard of care, and it was 18.9 months in the osimertinib arm, and with the hazard ratio of 0.46. And this was a kind of a you rarely see such strong and stark differences in the curves, and that's what was really impressive with this study. Next slide. And if we just see across all the subsets, whether with respect to race, age, smoking status, the EGFR mutations, all the arms favored osimertinib with a almost an average hazard ratio of 0.35 to 0.66. So across all subgroups, osimertinib was much better compared to the standard of care, which was either gefnib or lorlatinib. Next slide. Again, if you just see, so not only progression-free survival, but there was a actual difference in the objective response rates. So if you just see the response rates in osimertinib and the duration of response, both were higher. So response rates was 80% versus 76%, and duration response. So duration response was a combination of both partial response as well as the stable disease. So the median duration response was 17.2 months versus 8.5 months, and which was significantly higher in the osimertinib arm compared to the standard of care. Next slide, please. Again, one of the important second endpoint was OS, but then the OS was statistically significantly higher. And at the final analysis, at 58% maturity, if you just see the difference in osimertinib versus the TKI was a tune of around 7 months. So 38.6 months versus 31.8 months. So the final analysis of OS has shown a clinically meaningful and a statistically significant improvement in the EGFR TKI of osimertinib versus the first any of the first generation TKIs. Next slide. If you just see the adverse events, so if we compare osimertinib versus the first generation TKIs, diarrhea was a concern, but diarrhea does happen in the first generation TKIs also. So more or less the toxicity profile was favoring the osimertinib arm compared to the first generation TKIs. Next slide. So if you just see the comparatively, osimertinib was relatively safer with better quality of life compared to the standard of care. Next slide. So to summarize, osimertinib resulted in a statistically significant and clinically meaningful improvement in the PFS compared to the standard of care. Hazard ratio was 0.46, and there was a 54% risk reduction in the disease progression or death with respect to the standard of care, and with a very early separation of the curves and consistent benefit across all the subgroups which were predefined, and doubling in the duration of response with osimertinib compared to the SOC. There was a significant and clinically meaningful improvement in the CNS progression-free survival versus the standard of care. Again, hazard ratio was 0.48, and there were fewer CNS progressions in the osimertinib arm compared to the SOC. The final improvement in OS, again, very important thing is that there was a crossover which was allowed in the first generation, the TKI arm. So despite having a crossover and having an improvement in the overall survival is a really significant improvement. And I think that is one thing which has even some like 2-3 years back, people were still debating why can't we just have this in the second or third line? But it clearly shows that having this in the first line improves the overall survival. And the safety profile was comparable in both the arms. Next slide. I think so.
Sajjan sir, we cannot hear you. Yeah, I think your connectivity is low.
I think there is a connectivity problem. How many more slides are left?
So the time is almost over. So we need to conclude.
Okay,
Okay. So I can you hear me now?
yeah.
I've already made my point, and we can skip it in the interest of time. And back to the organizers.
Okay, thank you very much. That was a wonderful presentation. And any questions by anyone? I just want to ask any of your opinion on why Asians in PFS was lesser as compared to the other. Any comment on that?
So I think with each drug there are a lot of there will be some questions with respect to how a drug behaves better in one group compared to the other one. So that actually is a research question which you've asked. So it is possible, like we had seen this with respect to Gefnib. So Gefnib had a Gefnib had a positive trial in Asians, whereas it failed miserably in whites. So it is, I think, with respect to the pharmacogenomics and pharmacodynamics.
Yeah, probably the numbers were not very high to to give the accurate possibility remains that also. So thank you very much. That was a lovely presentation, and we have gone through this trial many times, and I think there are no more questions. Then we proceed on to the next session. Now, are we going to the session which is sponsored by Novartis?
Yes, sir. We'll continue with the same.
Okay.
In the same sequence, and we'll take on the debates later on, sir.
Okay, wonderful. So basically, we have become well versed with the common mutation in lung cancer. The problem comes only in the rare mutation when the NGS report shows us many other like exon 14 skipping or BRAF mutation. We do not know what to do in that. So in that context, I think the first topic is role of capmatinib in exon 14 skipping mutation, and it will be delivered by Dr. Arya, who is a director in medical oncology in Max Hospital, Saket. So I'll request Dr. Arya to proceed with his presentation.
Yeah, good evening, everyone. Good evening, Dr. Rajeshwar, and thank you, Dr. Sandeep Pickard, for the invitation. I'm doing it from my car, so bear with me if the connectivity is an issue at times. So the topic for today is capmatinib unlocking the unmet need in MET exon 14 skipping non-small cell lung cancer. Next slide, please. So I think we've heard the previous talks. I think Sajjan talked very lucidly about EGFR. We had Dr. Sunil Pasricha talking about different mutation, and he also talked in depth about the MET mutation and alterations. So we know, to summarize what he said, MET mutation is reportedly exclusively of other mutations, including EGFR, ALK, which means you can have one but not the other, at least in the beginning. A MET mutation in the spike site leading to exon 14 skipping, resulting in MET juxtamembrane gain of function alterations, which were originally discovered in small cell lung cancer, have now known to occur in 3 to 4% of non-small cell lung cancers. And in fact, it's not just adenocarcinomas. They are also seen in other subtypes, including squamous cell carcinomas. We know that there could be a prognostic impact with worse outcomes. They also are seen in early stage diagnosis at older age. The next slide, please. And therefore, they are an important, predictive marker. They are also a prognostic marker. They are associated with worse survival. So this is one data where you can look at the Kaplan-Meier survival curves for OS in non-small cell lung cancer on the left, with orange being MET negative or no alteration, and blue being the MET alteration or MET mutation. And in fact, MET mutated or the orange curve, the survival is worse. And when you look at specifically adenocarcinoma as well, we have similar results with worse overall survival in the MET exon 14 harboring adenocarcinomas. Next slide, please. So the other aspect of MET exon 14 is poor response to immunotherapy. Now, remember, these are rare mutations, so data will mostly comprise of retrospective studies, but in a fairly large experience of about 147 patients in MET exon 14 skipping and SCLC, 24 immunotherapy were evaluated, and the overall responses were 17%, which sit much inferior to the expectations with and chemotherapy. The median PFS was in the range of 1.9 months. The median OS also at 18.2 months. And there are also individual case reports that suggest that pembrolizumab might not be effective for an SCLC with high PD-L1 expression and a MET exon 14 skipping. So this data is very similar to what we have come to expect with those patients who harbor a EGFR mutation or ALK fusion, where typically immunotherapy in combination with chemo or alone would not lead to the outcomes that you would expect in the non-altered population. I think MET exon 14 is mirroring that behavior in terms of responses to immunotherapy. Next slide. Now, there's very early evidence to say that MET inhibition prolongs survival in MET mutated stage 4 non-small cell lung cancer. So one retrospective study, another, again, robust numbers, 148 patients with MET mutated metastatic non-small cell lung cancer who were treated with a MET inhibitor. There was early evidence to say that they had prolonged survival compared to those treated with other therapies. In the MET mutated population, those who received a MET inhibitor, the overall survival was 10.5 months, and compared to 5.2 months who had a MET mutation and concurrent amplification. And in fact, when these patients did receive a MET inhibitor, crizotinib or a capmatinib or glisatinib, the survival actually improved to 24.6 months. So improvement in median OS in those patients who are able to receive MET inhibitor in case there's a MET alteration. Next slide, please. So coming to capmatinib, we have different MET inhibitors. Crizotinib was one of the first MET inhibitors. I still call it a poor man's MET inhibitor, but we've also have had other drugs like cabozantinib, tepotinib, savolitinib, and now capmatinib. Capmatinib is an oral ATP competitive, highly potent, selective, and reversible inhibitor of MET kinase. It has a very high selectivity for the MET receptor kinase at more than 10,000-fold selectivity against 55 other human kinases. It has the ability to cross the blood-brain barrier, and therefore there's some evidence, albeit preliminary, to show brain activity. And then there's a potent blockade of MET activation at cell-based functional and biochemical assays. And when you look at the potency in terms of inhibition at 0.6 IC50, it's the most potent inhibitor compared to other MET inhibitors like tepotinib, crizotinib, etc. Next slide, please. So the study that actually looked at the drugs was Geometry Mono 1. So this was a slightly complex study. This was a multi-center open-label phase 2 trial, which evaluated the efficacy and safety of single-agent capmatinib in adults. Remember, these patients had to be stage 3B or 4 non-small cell lung cancer, had to be adult, any histology, EGFR and ALK wild type, and MET dysregulation had to be there by central assessment, and they were allowed they were allowed to have different kinds of mutations. So there were different cohorts. Cohort 1 was a pre-treated cohort of MET gene copy number of more than 10. Cohort 1A was more than 10. 1B was a gene copy number of between 6 and 10. 2 was pre-treated patients with MET gene copy number between 4 and 6. And cohort 3 was pre-treated patients with gene copy number less than 4. And then importantly, cohort 4, which we will discuss in some more detail later in the slides, was pre-treated patients with MET exon 14 skipping regardless of the gene copy number. Cohort 5, again, they were now treatment naive. 5A was MET gene copy number of more than 10 and no MET exon 14. 5B was MET exon 14 skipping regardless of MET gene copy number. And then there were the post-marketing cohorts, cohort 6 and cohort 7. All of these patients received capmatinib at a dose of 400 milligram twice a day. Next slide, please.
We can't hear you. Are you there?
Yeah, am I audible now?
Yeah.
Yeah, so key secondary objective was to look at duration of response. And then there were other secondary objectives which looked at overall response rate and duration of response rate by different cohorts, time to response, disease control rates, and then overall survival by cohort, adverse events, and plasma concentrations, etc. Next slide, please. So these are the baseline patient characteristics, and we are focusing predominantly on cohort 4. Remember, cohort 4 was MET exon 14 skipping. They were pre-treated patients in cohort 4, and then treatment naive in cohort 5B. So when you look at age, generally when you look at age, the median age was around 71, and PS, on expected lines, significant number of patients were either current or ex-smokers. I think that sits differently compared to what we see from the EGFR and ALK trials. Histology was a reasonable mix of adenocarcinoma, squamous and large cell carcinomas, and then you had different spectrum of concurrent gene amplifications measured based on the gene copy number. Next slide, please. So, as I said, when we look at the pre-treated cohort, a significant number of patients had earlier 1 or 2 lines of therapy. And when previously treated, most of these patients had platinum-based chemotherapy in the first line, and then single-agent chemotherapies in the subsequent line setting. And a small number of patients also had prior exposure to immunotherapy, either in the first or the second line. Next slide, please. So what were the best overall response rates in cohort 4? So when you look at pre-treated patients with MET exon 14 advanced non-small cell lung cancer, when you look at overall response rates were 40% in the blinded review, which sits very similar to 43% based on the investigator assessed overall response rate. And importantly, duration of the disease control rate is fairly impressive at 79% for the pre-treated population. Next slide, please. So cohort 5B is the response rate in the treatment naive population. Again, very impressive overall response rates at 68% and disease control rates of 96%. So superior overall responses and disease control rates in the population of patients who are treatment naive compared to those who are previously treated. Next slide, please. Now, when you look at tumor shrinkage, when we talk about overall response rates, obviously we look at RECIST criteria, but when you look at tumor shrinkage, majority of patients in both the cohorts having some tumor shrinkage on capmatinib. Next slide, please. So the other interesting point is the duration of response. So when you look at treatment-naive population, the duration of response is 12.6 months with capmatinib, and in those patients who had a pre-treated population, so cohort 4, the duration of response is 9.7 months. Next slide, please. And then when you look at progression-free survival, median PFS 12.42 months in the treatment-naive population and 5.42 months in the pre-treated population with capmatinib. Next slide. And when you look at Swimmer's plot for responders as well, so we look at fairly rapid and durable responses across both cohorts. And when you look at when do these responses start occurring, the onset of first tumor evaluation. So 82% in the cohort 1 population or cohort 4 population had a response at the first tumor evaluation, and similarly, nearly 70% of patients in the cohort 5B population, so untreated population, also have fairly early response and response, in fact, at the first tumor evaluation. Next slide, please. What about intracranial activity? And I think increasingly we are looking at drugs which have more CNS potency. So again, numbers are small. Remember, mutation is not very common. There were 13 patients which were evaluable with brain mets at baseline. When you look at this population, 7 out of those 13, so 54% patient had an intracranial response. These patients had a complete resolution of all brain lesions. And of the remaining 3 also, they were fairly impressive responses. And intracranial responses were also fast, similar to the responses elsewhere. And in the rest of the patient also, was a fairly impressive intracranial disease control. Next slide, please. Again, interesting to look at what kind of MET alteration leads to tumor shrinkage. We could see that deep responses were observed independent of type of MET mutation. So whether it was a SNV or NDEL, we had a good response. Also, irrespective of co-occurrence of a MET amplification, we had deep responses. Next slide, please. So when you look at the updated results from the cohort 4 and 5B, next slide, we have some more impressive data. Again, overall responses maintained at the updated analysis, and in the post-marketing analysis in the cohort 7 also, we are seeing fairly impressive responses with a disease control rate of nearly 100%. Next slide, please. Can I have the next slide, please? So when you look at disease control rate in the first line, this was the data. Next slide.
Next slide.
And when you look at, and when you look at patients and responses in the second or subsequent lines, again, overall responses fairly high at 40 to 50%. Ranging between 10 to 12 months lines and 5 to 10 months in line, and duration of response again 8 months in first line and lines. Slide, please.
So request you to kindly conclude your presentation in 2 minutes.
So clinically meaningful median overall survival at 20.8 months for the treatment naive population and 13.6 months for the pre-treated population. Next slide. And when you look at adverse events, so most of the adverse events were mild. They were predominantly peripheral edema, GI symptoms, increased blood creatinine. They were the most frequent as adverse event, but serious adverse events were fairly more limited. Next slide, please. And it does appear to be a fairly well-tolerated drug. And so, in conclusion, the preliminary results show excellent efficacy in the results of the expansion cohort with 66% as compared to those patients who have previously treated in the cohort 5B, which is 68% response rates in the treatment naive population. Again, overall response rates in the second or third line setting fairly around 40 to 50%. When the first case 20 months and 8.6 months in the pre-treatment setting.
Dr. Are you not audible?
Hello, am I audible now, sir?
Yeah, now you're audible.
Yeah. So I think given the results, any tumor, any alteration in MET exon 14 skipping, I think the drug of choice now has to be capmatinib.
Thank you, Dr. Arya. That was a wonderful presentation. At least basically, we have to get testing done for more patients. We are only doing probably EGFR for all those, or ROS, ALK at the most, and MET is not in the picture because the free coupons are not available to most of our patients. But obviously, as more and more patients we are going to do testing, we'll find this is a very, very, as you said, that they don't respond to the standard line of treatment. And from where I hear, I have not used it, but what I hear is the side effect is not diarrhea. The classical side effects are not there. Minimum side effects and response rates of up to 60 to 70%. So wonderful presentation. Any questions? If not, I move on to the next presentation. Next presentation is on the role of BRAF mutation in non-small cell lung cancer. And it will be presented by our organizer and friend, Dr. Sandeep Ukar, who is the head of Department of Medical Oncology at Sohana Hospital in Chandigarh. Dr. Sandeep, please.
There is some problem with the slides. Let me adjust.
Can the organizer please share the slide, please?
So is it visible, sir?
Yes.
Yes, sir. Just make it full screen, sir.
Okay. So good evening, everyone. Exploring the rare mutations and choosing the best therapy for each and every mutation has been our goal as a clinician. So we will understand about the use of BRAF inhibitors in metastatic non-small cell lung cancers. So disclaimer, the slides have been provided by Novartis. We will understand the role of BRAF inhibitors in metastatic NSCLC and gain the awareness of its testing methods and diagnosis, and the clinical data related to dabrafenib and trametinib, which has been the choice of therapy as a category 1 recommendation in patients who are BRAF mutated. So what is BRAF? It is the RAS-RAF pathway plays a key role in the cell proliferation. We all know that MAP kinase has been an oncogenic driver. This pathway regulates the cell signaling, and the mutations in the MAP kinase, including the BRAF mutations, have been reported in many of the cancers like melanoma, colorectal, thyroid, and to an extent in the NSCLC to the proportion of around 2 to 4%. So BRAF mutations, they lead to a constitutive BRAF activation and an uncontrolled signaling that lead to invasion, metastasis, proliferation of the cells, and the inhibition of the use of these inhibitors leads to inhibition of angiogenesis. So BRAF mutations in NSCLC, they occur to the proportion of 2 to 4%. They have been known in other cancers as well. In contrast to the other oncogenic drivers, the key patient characteristics or indicators, they have not well been characterized. BRAF mutations, they do not appear to correlate with age, sex, stage of diagnosis, or the smoking status, as we have seen with other mutations like EGFR and ALK, which are more predominantly seen in the female sex as well as in non-smokers. So some of the studies again suggest that BRAF mutations are likely to occur in females or those who have a history of smoking. So BRAF V600E is the most common driver mutations amongst the BRAF mutations. There are BRAF V600E as well as non-BRAF V600E mutations. So there are different types of mutations and different strategies. We need to look for the different type of strategies for dealing with these kind of mutations, because different strategies are required for treatment of NSCLC, bearing whether it is V600E or non-V600E. So in a retrospective analysis of around more than 1,000 tumors, BRAF mutations were present in around 4% of the adenocarcinomas, and 60% of them were V600, as well as 40% were non-V600. So we all know that patients with BRAF mutations, they have a shorter median overall survival. They clearly indicate that these are the kind of aggressive tumors, and we have a choice of therapy that was the platinum doublets, and we have been using in these kind of patients before the advent of the BRAF inhibitors. So BRAF patients with advanced BRAF V600E had worse outcomes with platinum-based therapies, including the DFS as well as OS, if you compared with the wild type of patients. So here in the graphs, you can see whether it is the wild type, they fare better compared to the BRAF ones. So ultimately, the behavior of these kind of patients was that of a clinically aggressive patient profile and with limited treatment options. So again, amongst the V600E and non-V600E, the patients with V600E, they tend to have a worse outcomes with platinum-based chemotherapies, including the ORRs, PFS, OS, than the wild type, as well as patients with non-V600E. So overall, in conclusion, patients, those who have a V600, those who harbor a V600E mutation, they fare poorer as compared to the wild type, as well as with the non-V600E patients. So that is why this remains an area of challenge, that remains an area of exploration. Why? Because in 1/3 of the patients will remain untreated. You can see from the research papers that around 1/3 of the patients will receive best supportive care in the first line. 60% of the patients will receive BSC in the second line. So overall, apart from the platinum-based doublet therapy, we did not have any other treatment options. And these kind of patients, they had a shorter survival. So patients with a mutation driver not receiving the targeted therapy lived 1 year shorter than those who were having a actionable driver mutations. So that was the goal when we could identify that the patient is harboring a BRAF V600 mutation and a targeted therapy was available. The survival was long, and this has been the summary so far. That is, we all know that patients with advanced NSCLC, the first choice is either platinum doublet or plus minus bevacizumab or a single agent chemotherapy, followed by a maintenance, and followed by in the second line you use immunotherapy. But the treatment lines for the patient, those who harbor a driver actionable mutations, have been different. So with the advent of broad molecular profiling, as has been stated by the speakers earlier, so we have been able to pick up the kind of patients that these could be the very, very suitable candidates for administering a particular type of therapy. So broad molecular profiling has been the cornerstone of testing as well as the clinical paradigm in these kind of patients. So ESMO consensus, it clearly states that broad molecular profiling should be done for patients with rare driver mutations, including BRAF. Again, NCCN guidelines, they recommend that the broad molecular profiling should be tested, including the rare driver mutations like the BRAF, ROS, and HER2 mutations as well. So upfront BRAF testing is very, very essential. Why? Because it does not appear to correlate with any of the clinical risk factors like age, sex, smoking history. They are more aggressive, and patients where we can target these mutations, they have a better clinical efficacy compared to the non-BRAF ones. So broader molecular profiling and the targeting the BRAF V600 mutation has been the cornerstone of therapy in patients who are BRAF mutated. What is the clinical data behind it? You have two drugs, dabrafenib and tremelimumab, which actually work synergistically. So dabrafenib is a reversible, potent, selective inhibitor of RAF kinases. It is the V600E and V600K mutation, particularly effective against BRAF 600E and V600K mutations. And tremelimumab is a reversible, highly selective active, which has got a highly selective activity against the MEK1 and MEK2 kinase. So DGCI has given an approval for dabrafenib in combination with tremelimumab for patients with V600E mutations. So why the combination? What is the rationale behind the combination? We all know the combination therapy could target the multiple portions of the MAP kinase pathway. So again, in NSCLC and melanoma, compared to the BRAF inhibition alone, that will be covered in the further slides. BRAF and MEK inhibition, they tend to act synergistically. They tend to delay the development of resistance, and they inhibit the cancer growth very, very effectively when ralfinol or dabrafenib is used as a single agent. So this was the overall trial design, where stage 4 NSCLC patient with a good performance scale, no prior treatment with a BRAF or MEK inhibitor, and a asymptomatic, non-stable 1 centimeter brain mets were excluded. So there were 3 cohorts, A, B, and C. A was pre-treated with monotherapy dabrafenib 150 mg BID. Cohort B was again previously treated 1 to 3 prior treatments, and it was a combination therapy. C was a treatment naive cohort, where again the standard of treatment dabrafenib with tremelimumab was given. So again the data was assessed. Primary endpoint was a ORR. Secondary endpoint was PFS, DO, duration of response, OS, and the safety signals. So in the cohort A, 2/3 of the patients were smokers or former or the current smokers. Nearly all the patients had a adenocarcinoma histology, and half of the patients were in second line on beyond. So these were the kind of patients who had earlier been treated with chemotherapy. Again, in the cohort B, it was again a previously treated cohort, but we used a combination of therapy which acts synergistically. Nearly all patients are adenocarcinomas, 3/4 were current or former smokers, 1/3 had received 2 or previous lines of therapy. So this was the cohort C, where all the patients are adenocarcinomas, and majority of the patients were, again, they were current or former smokers to the tune of around 70%. So phase 2 study, it enrolled around 169 patients, 78 in the cohort A, 57 in cohort B, and 36 in cohort C. Majority of the patients were adenocarcinomas and the current smokers. So in cohort A, so you can see here the overall response rate, ORR, I'll show in the graphs as well. So this was the progression-free survival was around 5.5 months. Median overall survival was 12.7 months. ORR was 33%, and disease control rate was 58%. So again, in cohort B, the investigator assessment, ORR was around 63%. Duration of response was seen for around 9 months. So we can see here the ORR, maximum tumor shrinkage, was seen in around 63%. Here the plots show that. Duration of response was again 9 months versus independent assessment of a 9 months. So 50% of the responses were ongoing at the time of data cutoff. So the combination therapy was, it clearly demonstrated that PFS with combination therapy was almost double to what has been demonstrated by dabrafenib, which demonstrated that dabrafenib and tremelimumab, they actually work synergistically, where the PFS was around 5.5 months, and here it was around 9.7 months. So again, in the cohort C, you can see here that the ORR was around to the tune of 64%, disease control rate of around 75%, and duration of response of 10.4 months was seen in cohort C, which was a previously untreated advanced BRAF V600E mutant population. So ORR of 64%. We can see here the waterfall plots clearly demonstrated a very good activity and a very good overall response rate. Duration of response was around 10.4 months, which was very good, and compared to the cohort A, where single agent was used, it was almost doubling of the duration of response. Again, PFS was, if you see the independent assessment, it was around 14.6 months, which is around actually 3 times of what we had seen with the single agent, and twice that of if we see it as a single agent therapy, that is 10.9 months. So here, if you see progression-free survival of around 5.5 months compared to 9.7 months in the heavily pretreated population, and 10.9 months in the patients who were treatment naive. Duration of response was again 9.6 months, 9 months, and 10.4 months. So the trial clearly demonstrated that the combination of therapy should be the treatment of choice, in particularly in the treatment naive population. So adverse effects, what I have used in few of the patients, and the only side effect that we usually see is the pyrexia. And at
request you to conclude it in 2 minutes.
Yeah, sure. So at times it becomes difficult to control pyrexia. In very few number of patients, you can control it by using simple antipyretics. So the discontinuation rate in the original trial was to the tune of 14%, and the serious adverse effects were very, very less. So pyrexia was the most common, and 2% of the patients had grade 3 pyrexia. So only fatalities that were seen were unrelated to the medication, was seen in 4 patients: retroperitoneal hemorrhage, subarachnoid hemorrhage, respiratory distress, and the neoplasm progression. So these are some of the side effects that we have already covered, and the treatment is either interrupt the treatment first and then use antipyretics, and majority of the patients, they do well with the interruption of treatment and the use of NSAIDs and paracetamol. You can use corticosteroids in some of the refractory cases where fever, despite reducing the dose of dabrafenib and tremelimumab, it fails to come down. So first is interrupt the treatment, use antipyretic, and decrease the dose of dabrafenib. You can continue the dose of tremelimumab in the same dose, and in refractory cases use steroids. So we all know what is the dosing. So summary was that the safety profile is very well manageable. The side effects that are seen are only pyrexia and GI related toxicities. Pyrexia is the most commonly observed, and although very, very few proportion of the patients have grade 3 or grade 4 pyrexia, which actually requires the intervention. So these are the references, and thank you all for patient listening, and I'll be happy if there are any questions.
Thank you, Dr. Sandeep. That was a good class. I remember my college days. Wonderfully, you explained each and everything very lucidly. And I think we have to do more testing in our patient and find patients which are specific for specific driver mutation. Any questions for anyone? Only pyrexia is probably side effect, and I have not used it. Probably it is manageable. That is what.
Yeah, I've used in 2 or 3 patients, and majority of the times pyrexia is the one thing that we need to see, and it is well managed by using antipyretics. And my patient did not require a dose reduction, fortunately.
Okay, thank you very much. And since we are constrained of timing, so we proceed on to the next session, which is sponsored by Astra. So in this, we have a debate on the first generation, second generation, and third generation. Now, to start the topic on the third generation, is Tagrisso the right choice for first line? We have with us Dr. Jatin Sareen, who is a director oncology at Ivy Hospital and CDC Chandigarh. He is probably the senior most oldest medical oncologist, not in age, in terms of as far as the time period is concerned, oncology in Chandigarh. He is a pioneer of starting oncology rather in the Tri-City. So I'll request Dr. Jatin to proceed with his talk.
Am I audible?
Yes.
First of all, thank you, Dr. Rajeshwar, for your kind words, and thank you, Sandeep, for giving me the opportunity. And I'll be sharing my screen. Is it visible?
Yes.
Perfect.
Make it full screen.
Yeah. So thankfully, my previous esteemed speaker, Dr. Sajjan Raj Purohit, made my job really easier. So I'll be rushing through some of the slides, and rather I would be saving the time of the organizer. The debate is Tagrisso the right or osimertinib the right choice in the first line? First of all, I want to thank AstraZeneca for helping me with the slides. So our first line options for EGFR mutated, we all know first generation, second generation, third generation EGFR TKI, and osimertinib is the third generation EGFR TKI. FLAURA study was in detail elucidated by Dr. Sajjan Raj Purohit, and the primary endpoint was PFS, and the secondary endpoints were ORR and OS. And osimertinib demonstrated improvement in median OS and median PFS, unprecedented median overall survival, unprecedented median progression-free survival, and duration of response was also unprecedented. And so this is the thing comparing PFS and OS in different TKI, including first, second, and third generation TKI, and you can all see these bar graphs. And 18.9 months was the PFS, and 38.6 months is the OS, and these are all in the first line. So it was a well-conducted prospective randomized phase 3 study, and you can see among the PFS, all the subgroups, be it age, be it race, be it smoking history, CNS metastasis, and that is the most important point, CNS metastasis, kind of EGFR mutation, the two most common being exon 19 del and L858R, and the PFS was better as compared to the first and second generation TKI. And the OS, yeah, some people raise question as far as the Asians, they were not much benefited as far as the OS is concerned. So it was rightly asked by Dr. Rajeshwar also in the previous lecture. And again, I would like to reiterate that the numbers were not adequate to establish the difference. Otherwise, all kinds of patients or all kinds of subgroups were benefited with the first line of this TKI. So it was PFS was maintained across all subgroup, and OS subgroup showed a positive benefit, although the magnitude of benefit varies. So these are our NCCN guidelines, and as you can see that there are many options these days. All are category 1, and but the preferred choice is osimertinib. And even if you have started with chemotherapy, and then you can always follow it up with osimertinib. So it's a strong recommendation as a first line usage. So let's compare it with the most closest of the competitor TKI, that is dacometinib, and this was the trial which we call Archer trial. And this was, the difference was it was an open label studies and and while osimertinib was a double blind study, and patients with history of brain or leptomeningeal metastasis were excluded, while in osimertinib, the patients with CNS metastasis, which are actually very common in EGFR mutated patients, are included. The median PFS was 14.7, while in osimertinib it was 18.9. And the Kaplan-Meier curves or the survival curves actually separate after 6 months of treatment, while this was shown aptly in the Flora trial by Dr. Sajjan, that they start separating right from the start. And in this particular trial, actually a hierarchical gatekeeping procedure was used for hypothesis testing, which is not the ideal thing, and therefore OS was more of a you can see an estimate rather than a formal assessment. So we cannot actually believe the OS. And the other thing is that ORR, overall response rate, between the there was not much of a difference between the overall response rate of the comparator arm versus the treatment arm. And median OS was estimated to be 34.1 months, and this was 38.6 months. The other important thing was that dose reduction in this particular study, the dose reductions were done in 66% of patients, and serious adverse events were seen in 27% of patients, and adverse event leading to death were also there, but it was there were hardly, as compared to dacometinib, much of dose reduction and serious adverse events in the osimertinib. So it was a much better tolerated TKI, third generation TKI. these are the graphs we have already discussed. The graphs tend to separate after 6 months in Archer, and they start separating immediately. Overall survival of Archer, and this is how the hierarchical testing was done. The PFS was better than overall response rate was tested, and overall response rate didn't turn out to be better. But a formal assessment of OS could not be done, and the trial hierarchical testing rules, the gatekeeping procedure was stopped at testing of ORR, as it was not statistically significant. And this was also mentioned in the paper which was published, and was shown that a formal assessment of OS could not be performed. This is another important TKI, afatinib, and this also failed to show an OS advantage over the first line. And so what about the CNS metastasis, which are an important cohort of patient in EGFR mutated patient, and they were included in the FLORA trial, and you can see the intracranial CNS PFS with a measurable or non-measurable CNS was not reached with osimertinib, and 13.9 months with standard EGFR TKI. The overall CNS response was 91% against the 68% with the other TKIs. So people argue that osimertinib is a very good weapon, and why don't we use it sequentially in the second line? So the argument is that if you start 10 patients with the first or second generation TKI, from there about 73 to 77% they go on to receive second line, 30% drop off and die during first line, or receive only palliative care upon progression. Out of these 73 to 7 or roughly 75% of patients, 60 to 76% get a valid T790M test results, and out of those you have 50% of those with valid test results are T790M positive. So 7 out of 10 patients who start on first or second generation EGFR TKI will not be able to receive osimertinib in the second line. So we are depriving those 7 patients of the best available agent, leading to the best progression-free and overall survival. And this is the upfront and the sequential treatment arms. So 1/3 of patients are T790 mutated, 1/3 are T790M or unknown, and 1/3 are no second line therapy. So weighted average PFS, if we use sequential EGFR TKIs, then the weighted average PFS comes down to 15 months, while if we use osimertinib as a first line, it is actually 18.9 months. The PFS is due to all these factors. Again, the sequencing, as you can see, the OS with these sequencing are not actually reaching up to 38.4 months. So this was a big study by in the afatinib group when they said that this geotag study led to a better OS while as compared to osimertinib, which was 38.6 months. But there were some inherent flaws in this study. It was a retrospective observational analysis, and there was a selection bias in the patient. Excluded patients who were T790M upfront negative or not tested, died on first line afatinib, and could not receive second line therapy. So all these bad prognostic patients were excluded. So there was a selection bias. There was higher incidence of specifically DEL19, and also in this particular subset, when they progress, the patients who had initiated osimertinib more than equal to 10 months before enrollment were included. So shorter treatment durations of patients were excluded. So more number of patients who were persistently on more than equal to 10 months of osimertinib were included. So TTF cannot be compared to PFS, and OS was again exploratory. So there should be a direct head-to-head comparison if we really want to show that sequential strategy is better than. Now the people argue that what after osimertinib? So now there are various studies which are coming up, and the resistant mechanisms post osimertinib has been identified, and newer agents are coming up, like combination with the MET inhibitors. There are some mutations like C797S in which you can switch over to, or in addition add to osimertinib, geftinib. So various studies are coming up, and there is one more study among these Orchard trial, and then you have Chrysalis trial, which was reported recently in the ASCO. The combination of amivantamab and lazertinib post osimertinib or chemotherapy progression. So the field is actually evolving, leading to much more increase in the overall survival of these patients, EGFR mutant patients. Then people tried to combine these TKIs with chemotherapy.
My apologies, sir. You need to conclude your presentation in 1
Sure.
minute. Thank
Yeah. So we our very own TMS study was a very good study, and definitely it was showing comparable PFS and OS, but at the cost of increased toxicity. There were more grade 3 toxicities there, which occurred in around 51% of patients. And the same goes for a combination of anti-VEGF along with the TKIs, and again the PFS were definitely prolonged, but the overall survival data was not clear. Plus, there were more grade 3-4 emergent adverse event. There are a subset of patients who might benefit, but it is still exploratory. But these two strategies are for particular subsets of patients, which I'm not going to discuss here. Otherwise, osimertinib in both the cases is a valid and a most tolerable treatment option. So you can all see the most important thing was the more grade 3 side effect. So why osimertinib first line? Improved PFS, OS, greater intracranial efficacy, better tolerability, and convenience of being able to offer it without even T790M patients. And not everyone will be well enough to receive additional treatment. If you say sequencing should be the ideal thing, 30% of patient drop off, and tissue liquid biopsies are not always successful, and osimertinib alone is associated with survival benefit. And to summarize, upfront osimertinib leads to OS of 38.6 months. And again, I would like to repeat that very particular night. Why provide the benefit of an efficacious and safe drug to only 3 out of 10 patients when you can provide it to all 10 patients upfront? So thank you, and back to the organizers.
Thank you, Dr. Jatin. I mean, you have put your point across that there's no doubt in anybody's mind. I think that this is the first choice. Osimertinib is the first choice in lung, and probably the safest. Thank you very much. But we have issues in our country, and we go on to the second topic, that whether the second generation and geotag type of sequencing is better for our country or not. And to present that their case, we have Dr. Bharat Vaswani. We know him very popular among our oncologists, All India Oncology setup. He's a senior consultant and medical oncologist and hematologist in Yashoda Hospital, Hyderabad. Recently, he was gunning for osimertinib as a first line, and he proved his point there. A couple of months back, I heard him, and today he's on the opposite side. That is second generation TKI sequencing. Is it the right strategy? So, Dr. Bharat, please.
Good evening, sir. Sir, thanks for a kind invitation.
Thank you.
Sir, important. Sir, audible? Am I audible? And
Yes,
on the
yes.
slide
You are
visible?
audible. Yes, audible.
Okay. So first, let me thank Sandeep, my younger brother, for the kind invite, Tarun, and I'd like to thank Sahu sir and Satya sir for helping me prepare these slides. Now, the basic thing I'm trying to discuss is very well spoken by Dr. Jatin sir, my senior. The thing to remember is what I am debating today in the next 8 minutes, 9 minutes, I don't require more, is at the end of the day, is this approach the right strategy, and how do I prove my strategy right? Now, so the most important universal truth everybody remember is all that glitters is not gold. All we discuss about osimertinib as a third generation is 18.6 months PFS. Now the problem comes when you start talking about the overall survival. There are so many lacunae that were there. I'll be presenting it in a single slide, but what you achieved was 38.6 months. Everybody will agree, and which was probably less what we expected, and the hazard ratio was just touching 1. So here and there, and you would have lost the significance. And the same holds true in our instance that I'll be discussing. Now, what is common sense? Common sense is seeing things as they are and doing things they are out to be. So what is common. But the irony is there is nothing more uncommon than a common sense. And the common sense says this: when we treat a disease, the most important thing is to get a combination which gives you a maximum overall survival. That is what we call as the most important point. So here comes my question: how do you get this maximum survival? And the maximum survival is you use all your effective drugs in a proper combination. We see this in head and neck when you discuss with cetuximab with immunotherapy. And the $1 million question is, what is the sequence? First, second, third generation TKIs, your osimertinib gives you a 18.61, which is better than first generation TKI. Please remember, there was no head-on studies which were compared second versus third generation. So whatever we have taken out is from the FLORA study. So you can never discount a study called as Geotech, which gives you a sequence and that give you, I'll be proving you that even if it is T790M negative, I can still get away by not giving it, and my survival will not be inferior to 38.6 months, which is there for osimertinib. So my discussion is based on 4 points. Is there a rationale of giving sequencing? Do I have a evidence to prove it? Or is it applicable to all? This is something that Jatin Sareen sir was telling 30%, but let me discuss about T790M negative. And last but not the least, in a country like India, is there a cost benefit analysis? So let me talk about the rationale. Every time sir tried to discuss that there are newer drugs available when you say osimertinib has progressed. Is there something available in India? Clisalis study, amivantamab plus lazertinib. This is not available in India. So let us discuss what is there in our country and let us try to prove it based on whatever the available resources. The first scenario, first or second generation TKI, 9 to 13 months, they progress. Please remember the T790M mutation is slightly more when you give a second generation TKI, around 60%. 40% are T790M negative. And we have already seen that third generation TKI, 18.9 months, and you progress, you use multiple of agents. There are a lot of mechanisms, but unfortunately, we do not have any drug which circumvent those resistant mechanisms. But the golden point was 38.6 months, and that is what I'm trying to discuss. What we all know is 60% of the patient who take a second generation TKI has developed a T790M mutation when they progress, and probably 60 is a big number. Now you give it, you don't know it. In an ideal population, I'm discussing that the patient is receiving this. So I have started my patient on afatinib. I have 11 to 13 months, and 60% of the time my patient has developed the T790M mutation. So what we all know is we know the pattern of recurrence when we give a second generation TKI. And more importantly, for this 60% of the patient, we have a drug which we know gives a better PFS and OS. Is it the same for osimertinib when given in the first line? The answer is a big no. We have tried to evolve getting this mechanism, but unfortunately, none of the drugs is available in the country. So what we all do is progress to our chemotherapy option, or we follow our immuno plus chemo combination, which I think is still experimental. Now I'm trying to discuss what are the evidences and applicability to all. So the most common scenario, which my colleague or my senior colleague will agree that he knows also, but I'll be trying to discuss both. What we have now is the available evidence. And I am not wrong to say that there is no phase 3 trial. So you cannot dispute that this is an inferior drug. Now, what afatinib trials were available? There were 3, Lux, Nun, 3, 6, 7. More important thing is for those patients who took osimertinib, the median time to osimertinib are in fact so high. So it was nearly close to 2 years now. So now what we're trying to understand is if they develop a secondary mutation, probably following a second generation, their duration of response is probably far better. Do I have evidence for it? So multiple papers presented suggest that those who have this mutation, probably their survival when we gave osimertinib in a sequencing is probably as good as 4 years. And we talk about afatinib, which I am trying to debate, is more than 50 months now. Do I have another evidence to support it? So what my colleagues suggested that it is exploratory. We need to understand that these were pre-selected patients who were EGFR mutation. It was done in multiple 10 countries and it is a big number. We started our patients on afatinib. These were pre-selected and they developed 3790M who are giving osimertinib. Now what we arrived was that is something, because I have 2 drugs which we have optimally used and my survival goes to 41.3. So another 3 months improvement. More important thing, what about exon del 19? So it was close to 46 months. So what I am trying to suggest is in a majority of patients, the survival is better when you sequence. Now this is what we call as Achilles heel. What about T790M negative patients? Now please look into the data. Even in T790M patient negative, osimertinib may not work at all. Do I have evidence? So there are multiple studies published, but I would like you to concentrate on second line study which combined placebo with chemotherapy in a second line, and here the survival was 22.5 months. So my point of contention is if it is T790M negative, osimertinib may also not do well. You remember, and chemotherapy may work equally well in the second line. And we have enough data to suggest that in a second line, given a chemo in those. So if I have a T790, I proceed to my osimertinib. If I don't have it, please remember that in a second line, the survival is close to 22 months, apart from what I have used in the second line. So what if I combine it? My survival still is 32 to 36 months. So even if there is no T790M mutation, I know chemotherapy works well. Please remember, my colleague next to it will discuss that TKI with chemo, and you remember there were chemo which was given for 16 months. So please don't discount that chemo may not work. Even if you are T790M negative, your chemo is supposed to work and it works, and you still have a survival of 3 years. Now that is more important. You are having a costly drug. We should always keep it for a country like India. How many of us can afford osimertinib and how many of us can afford osimertinib for 18 months? What about uncommon mutation? Again, the thing is when you 10% of the patient where you have an uncommon mutation, the head-on drug everybody agrees is afatinib, 70 to 80% response rate in a PFS close to 12 months. Now this is a head-on comparison that has been mentioned. Your third generation TKI in this uncommon is gives only 8.2 months, and when you combine your second generation or afatinib, it is 10 to 19 months. So there is no doubt in this 10% of the patient, your drug should be afatinib, and then if you have a T790M, again, if they get it, you can still give up your osimertinib. The last but not the least, in a country like India, where cost is always a constraint, please remember 70% rural population, proportion of cancer cost paid from the pocket, 70% not covered in any of your Aarogyasri program. And we know afatinib now has a generic version, and you can still give 10 to 12 months of osimertinib in the second line. So financial and sense, the most important thing is reducing physical and financial toxicity. Is osimertinib financially sound enough? So there are so many papers which have published that in a first line setting. This was a big paper in JAMA, not cost effective. Again, a paper which was published in Oncologist, not cost effective. what nice thing says, or what UK people has in the big paper published, that it could be considered cost effective compared to a patient drug of patient choice in the second line in patient with EGFR T790M mutation NSCLC in a UK paired bio. In fact, they are so much reimbursable. Still, they say that probably the best use is when you know you can spend from your pocket for 10 to 12 months. Cost, that is most important. So I have reduced the cost around 1 lakh, around 21 lakhs cost for osimertinib, and around 14 lakhs cost when you alter afatinib with osimertinib. So here also, probably the choice is yours when you can get the same survival when you can sequence. Why I should not use last two slides? Because post first line osimertinib, there are a multitude like MET amplification, FGFR, but please remember there is no standard second line available till now in India. The OS 38.1, 6 months as FLAURA is lesser than sequencing, which is 41.6 months. There is no overall survival improvement, exon 21. So what we discuss is 1919. The moment you come to 21, you have to give your chemo plus TKI or VEGFR plus TKI. Please remember, there was no improvement in overall survival in Asians. Now, if we are Asians or Caucasians, nobody knows. But yes, no overall survival in Asians. And please remember, you are using a costly drug. You have to use judiciously. We discuss effective drug, but please remember, this was only a PFS. The moment osimertinib fails, you don't have any drug to give it off at a very high cost. Why not chemo plus TKI? So probably if you look into all the studies, the Tata study and the NEJ study, the maintenance, or you need to continue 16 to 18 months of continuous chemo. Please remember in your practice, how many of your patients can take 16 to 18 months of continuous chemo, which is equal to the PFS in those studies. They both had chemo to be continued with TKI. And my previous speaker has very well said that around 70 to 90% of grade 2 to 4 toxicity. So you need an extremely fit person who may take this combination. And for a person who is old, probably, and a person with a poor performance, you may not choose this combination. So the last but not the least, is there a rationale of giving second generation TKI followed by third generation? The answer is yes. You can sequence it even in non.
Sorry to interrupt, but
last slide, madam.
okay.
Is there a rationale? There is a rationale. Do you have a evidence and its level? I have told you, please remember, the evidence is from what we have studied so far. Whatever evidence in any of the literature or any of the things suggests that yes, there is a evidence, this is applicable to all. And last but not the least, is there a cost benefit analysis? Do you have any doubt when you have a generic version of one drug and costly? So probably you can save your cost with the same improvement. I end my presentation with the very famous quotes of William James. Act as if what you do makes a difference. Please remember, you have a limited drug. And at the end of the day, what gives you the best overall survival with a manageable cost and with a scientific rationale you need to choose. I again thank, and I'll be happy to take the question. First, I want to hear a rebuttal from if Sarin sir can give me something. Thank you all for a patient hearing.
Thank you very much, Dr. Bharat. I mean, I knew that you were going to put up your case in a very forceful way. And probably you have convinced many people that this is also one of the, of course, there is no one single way, you know, all the ways, all the things are right. Anyone want to make any point on this? I'll give 1 minute for that. And if not, because time is short, and I know that people are not going to counter Dr. Bharat for his convincing presentation. And thank you very much, Dr. Bharat. There's no question and nobody.
So the debate will be endless.
I agree.
If we start countering, the debate will become endless. Yeah.
Absolutely, absolutely.
Yeah.
So we proceed on to the third presentation, which is again a very convincing presentation for our country, that is chemotherapy and Geftinib in a magical combination in an Indian setting. And we have Dr. Suhash, who is a consultant medical oncologist and hematologist at Asian Cancer Institute, Mumbai. He'll be giving his point in favor of a combination which is specific to our country. Dr. Suhash, please.
Thank you, sir. At the outset, I would like to thank the organizers, Dr. Sandeep, my friend, for giving this opportunity. So I would be discussing for next couple of minutes regarding this combination already. We have seen some of the negative aspect of this combination, but we are going to see some of the positive things as well.
Kindly put your
So,
slides on PowerPoint.
Yes.
Yeah, PowerPoint.
Yes. So we can see now this is the present scenario. We are able to identify the different driver mutation, and the problem is that, so basically the disease burden is quite
So
high. And
sorry
in the
to
India,
interrupt.
so
Can you make it the full screen?
no, it is not getting moved up when it is made full screen.
Okay, okay.
So basically the EGFR incidence ranges from almost 12 to 50%. And we have seen in the various Indian studies, it is ranging from almost 30 to 40%. So now coming toward the TKI, so what is the rationale? Combining these two treatment strategies would be now the chemotherapy and EGFR TKI, which would act synergistically by inducing the apoptosis, and they would suppress some of the signal regulated kinase phosphorylation, which is going to delay the development of the resistance. And oral TKI also decreases the thymidylate synthase level, which can enhance the pemetrexed efficacy. Basically, the rationale for this particular combination was coming from the phase 2 trials. We have seen that it can prolong the PFS as well as the OS. Now coming toward the main phase 3 study, which would compare the gefitinib and chemotherapy combination versus the gefitinib alone, which was designed and published from the TMH basically. So the eligibility criteria had the EGFR mutation, different EGFR mutation, even they have included some of the uncommon, including 18 as well. Along with those disease like stage 3B, which is not amenable to the radical treatment, or the stage 4, and patient having the good performance status. So this was a schema. Coming toward the intervention as a gefitinib and the chemotherapy, as we have seen chemotherapy as a treatment along with the gefitinib arm and versus the gefitinib. So we can see the response rate. So the response rate would be almost CR rate, which are seen in almost 2.9 versus 0.6% in the gefitinib arm, while the partial response quite high, 72.4 versus 62% in the gefitinib arm, while the progression of the disease was lesser in the gefitinib and the chemotherapy arm. So coming towards again, the overall response rate was quite high in the gefitinib plus chemo than the gefitinib, which was 62 versus almost touching to the 76%. And the median depth of the response was also very high. We can see almost 256.4 versus 243%, and in the gefitinib arm with a significant p value. So when we talk about the progression and the PFS, we can see the objective progression of the disease being lesser, as well as the event for PFS was also lesser with gefitinib and the chemotherapy, while the incidence of the obviously the death was even balanced in both these two arms, and the incidence of the loss to follow-up was also equal. When we talk about the progression and the PFS, the median PFS was significantly longer, almost double in the gefitinib plus chemotherapy as compared to the gefitinib arm, with 50% reduction in the risk of the disease progression. So when we see this subgroup analysis also, so all these favors, the subgroup favored the gefitinib and the chemotherapy arm as compared to the gefitinib alone. We can see the different subgroups going in favor of this particular combination only. So when we see the PFS2 second progression disease event, we can see the median PFS2 time was almost 14 months versus 23 months with a significant hazard ratio 0.69. So when we talk about the overall survival, so almost when we talk about the overall survival, again, the overall survival was statistically significant with the gefitinib and the chemotherapy arm as compared to the chemotherapy. It was not reached versus 17 months, and unadjusted hazard ratio was 0.45. So the estimated 18 months overall survival rate was 74 versus almost 48% in the gefitinib arm. So the only point of consideration would be the taking into the consider the toxicity profile of the gefitinib and the chemotherapy, and the second would be the acceptance to this combination by the patient when the option of the alone the TKIs would be there. So the all toxic, more than grade 3 toxicities occurred in almost 75% of the patient, as rightly pointed out by the previous speaker, and it was 50% in the gefitinib arm, while the serious toxicities were also common, 50 versus 25%, and excess toxicity was primarily having with the increased myelosuppression, nephrotoxicity, and the hypokalemia, while each arm had one fatal toxicity like febrile neutropenia obviously in the chemo and gefitinib combination, while interstitial pneumonitis in the gefitinib arm. Along with that, almost 17% in this combination, they were discontinued because of the various toxicity, like 11% nephrotoxicity, 3 patient febrile neutropenia, GI toxicity in 4 patients. While in 2 patient in gefitinib arm, also they are resulted in the discontinuation because of the ILD and non-neutropenic infection as well. So coming toward the similar points. So those patients who are progressed on the gefitinib, again, they received the chemotherapy after the progression. So we can see from this particular slide also, the PFS in this particular study was 17 months, which is comparable to the PFS of 18.9 months in the osimertinib from the FLORA study. So the PFS was attained in this study, which was very comparable. 21% of the study patient has a performance status of 2, but the FLORA included patient which were very PS1 or less. So again, the combination, this we know that this, although this osimertinib is an attractive option, but we have seen there are very much limitation, mainly the financial constraint to be taken into the consideration. Again, this combination of EGFR and the chemotherapy, it was given some of the very go ahead points from the NEJ 009 study as well. So to summarize, so this combination used in this trial is the only regimen that would prolong the OS over the standard of the care in EGFR mutated lung cancer, and this would be very much rational in Indian setting, particularly when majority of the patient won't be able to afford the osimertinib. The intratumor heterogeneity and the development of the resistant clone may be what drive the survival, and this forms the theoretical rationale for combining therapies with non-overlapping mechanism of action. Adding the pemcarbo chemotherapy to gefitinib significantly prolonged PFS and OS, but there was increased risk of the toxicity as well. So we can consider this particular combination, particularly for fit patients who are not able to afford the other standard of the care and maybe willing to accept this kind of toxicity. The combination represents a new standard of the care in first-line treatment of EGFR mutant NSCLC. Thank you.
Thank you, Dr. Swaj. That was wonderful presentation, and there is no doubt that even your previous speakers who were there, who were gunning for their drugs, they are using in practical terms in their day-to-day practice this combination. And we all have used this combination in majority of our patients, because most of our patients generally cannot afford those drugs. And there is no doubt we have a data and a published data from India which shows that this drug is not inferior. Of course, we have to have some, the patient should be of a good performance status who can, take this drug for such long time. So wonderful presentation. I think there is no need for any discussion or points in there because it is endless. So we proceed on to the next topic. The next topic is on immunotherapy. And the first will be the role of dual immunotherapy, the first line metastatic non-small cell lung cancer IO combination. It will be by Dr. Kothari, who is a consultant medical oncologist, Can Cure Cancer Center, Narayana Multi-Specialty Hospital, Ahmedabad. Dr. Kothari, please, with the presentation.
Yeah, thank you for the invite. I will be speaking on dual IO in first-line metastatic NSCLC, and I have taken liberty to add dual IO plus chemotherapy also. So I'll be talking on CheckMate 227, which is Nivo plus EP in first line, and CheckMate 9LA, where it is Nivo plus EP with 2 cycles of chemotherapy in first 2 cycles. So CheckMate 227, the patients of stage 4 NSCLC with no prior systemic therapy, no EGFR and ALK, no untreated CNS mets, PS0 and 1 were taken, and PDL1 more than 1% and less than 1% made 2 cohorts, 1A and 1B. and they were randomized. The primary endpoint was overall survival and progression-free survival. So in PDL1, more than 1% population, efficacy, overall survival, as we can see now, we have 5-year data. At 3 years, it was 33% versus 22%, Nivo EP versus chemo, and at 5 years, it is 24% versus 14%, with median overall survival of 17.1 months versus 15.7 months, and hazard ratio is 0.77, not crossing unity, which signifies that it is a statistically significant finding. Next slide, please. Again, in PFS, the hazard ratio is not crossing unity, and as we can see at 5 years, it is 12% versus 2% when compared with chemotherapy alone. Next slide, please. For patients with PDL1 less than 1%, again, overall survival at 5 years is 19% versus 7%. Median overall survival of 17.4 months versus 15.2 months. Hazard ratio of 0.65, not crossing unity, stating it is a significant finding. Next slide, please. Again, for PDL1 less than 1% patient, the progression-free survival with Nivo plus EP versus chemo is 5.1 versus 4.7 months. But as we are aware that it is more of tail, which is important. At 5 years, it is 10% versus 2%. Next slide, please. So at 5-year analysis, this is longest reported phase 3 study of first-line IO combination, where Nivo plus EP has shown a durable benefit when compared with chemo. At 5 years, it is 24% versus 14% for PDL1 more than equal to 1%, and 19% versus 7% for PDL1 less than 1%. And median duration of response is significantly high, as we expect with immunotherapy, because the patients who respond continues to respond. And they have done a specific analysis for 5-year survivor patient. So they have shown that patients who have maintained more than 5 years of responses are generally the ones who have responded initially, and more than 40% of the patients who have responded initially had response beyond 5 years, and most of them are off any treatment since 3 years, because as per protocol at 2 years they completed treatment. Quality of life was similar to general US population. So this long-term data support Nivo plus EP as an effective first-line treatment. Next slide, please. So I will discuss Checkmate 9LA, which is Nivo plus EP with 2 cycles of chemotherapy was compared with chemotherapy alone. And if it was non-squamous, pemetrexed maintenance was allowed. Again, stage 4 NSCLC, no prior systemic therapy, no EGFR ALK, PS01 were taken, and 1:1 randomization was done. Next slide, please. So again here, overall survival in all randomized patients, irrespective of PDL1, at 3 years, we can see that the difference is 27% versus 19%. Median overall survival 15.8 months versus 11 months. Hazard ratio of 0.74, not crossing unity. Next slide, please. So as per PDL1, for PDL1 less than 1%, the median overall survival is 17.7 versus 9.8. And for PDL1 more than equal to 1%, it is 15.8 versus 10.9 months. Both hazard ratio 0.67 and 0.74, and confidence interval not crossing unity. Next slide, please. And the results were similar for PDL1 1 to 49% and PDL1 more than equal to 50%. Next slide, please. So the author has concluded that efficacy outcomes in all randomized patient and subgroup of PDL1 expression at 3 years of follow-up, the efficacy, the combination is efficacious. 3-year efficacy was 27% versus 19% for overall survival, 13% versus 5% for PFS, and 23 versus 14% for duration of response. And 3-year overall survival rate for PDL1 less than 1% was 25 versus 15%. PDL1 more than equal to 1% was 28 versus 19%. And the overall survival benefit was seen across PDL1 1 to 49% and more than equal to 50%. Again, this trial had both non-squamous and squamous. So the 3-year overall survival rates in non-squamous was 28 versus 23 and 24 versus 11 in squamous. Next slide, please. So now what we need to think over is whether this is a combination which has to compete with pembro plus chemo or atezolizumab plus chemo or ABCP arm. So why should we consider doublet over this? So as per my understanding, most of us are not using doublet IO because of financial toxicity. Again, the toxicity profile is not very much different when you compare it with chemo plus pembro. Rather, there were more discontinuations than pembro plus chemo or ABCP arm. So toxicity profile is not a reason why, because just patient want to avoid chemotherapy, we are giving the dual IO. So that is something which we need to ponder over when we consider dual IO versus pembro plus chemo or ATES plus chemo combination. And again, there is inexperience amongst the oncologists to use ipilimumab due to financial reason, and second, because the results are largely similar in pembro plus chemo and ATES plus chemo, we are not feeling the need to use ipilimumab. This is what I think why this regimen is not as commonly used as what we use IO plus chemo combination. I think this is the last slide. Thank you.
Thank you, Dr. Kothari. I mean, that was a wonderful presentation. Anybody has used this combination, and what about the side effect in especially elderly patients? And any comment from anybody? Okay, if there are no comment, thank you very much. And we move on to our next presentation, which is a long-term survival outcomes with nivolumab in metastatic small cell lung cancer. It will be presented by our friend Dr. Chitresh Agarwal, who is a consultant medical oncologist at Alchemist Hospital, Panchkula. Dr. Chitresh, please.
Good evening, all of you. Good evening, sir. Good evening, Dr. Cooker. Thank you for giving me this opportunity. Surbi, I would be able to share my screens now, so kindly allow me to do that.
Yes, sir, you can share.
Are the slides visible?
Yes.
Yes, sir.
PowerPoint.
And time and again, our discussions on the new kids on the horizon, immunotherapy, immuno-oncology drugs, the fantastic discussions by Dr. Rushabh and my friend Dr. Chitresh. I would like to thank the attendees and the fellow doctors. And in the end, our event sponsors, Dr. Lal Path Labs, Novartis, AstraZeneca, Adlay, and BMS. And a final concluding remarks. I would also like to thank our event management, Healthy Blossoms Event Management. Thank you all who have been a part of this CME and making it a successful one. Thank you.
Thank you, sir. Thank you so much. Thank you, Surbhi. Thank you, Mahima. Thank you, sir. Good night. Stay safe.
Good night.
Support team, we can close the meeting.
Okay, ma'am.